Welcome everyone. Thank you for joining us for today's webinar. My name is Marian. Today we are presenting Improvement Resuscitation Service in Tung Eastern Hospital, Hong Kong, presented by Ms. Erica Ho. Ms. Erica Ho is a Fellow of Hong Kong Academy of Nursing in Neurosurgery. She has worked in Queen Elizabeth Hospital since her graduation and transferred to the current hospital since 2012. Previously, Erica was the case manager in the image-guided neurosurgery and radiosurgery, responsible for the initiation and supervision of the logistic arrangement for the smooth running of services. She joined PWEH in 2012 as the APN in Quality and Safety Office to assist the hospital in the quality improvement project and hospital accreditation. She is actively involved in various committees, including Hospital Quality and Safety Committee, Hospital Accreditation Steering Committee, and Resuscitation Subcommittee, in which various hospital-wide quality and safety projects are implemented. Just a little housekeeping before we get started. If you have questions during the webinar, you can type them into the questions pane and click send. The presenter will be answering questions after the presentation. Recording of today's webinar will also be available at the IHF website. Now, without further ado, we'll turn the time over to Ms. Erica Ho. Ms. Erica Ho, you can start with your presentation.
Hello, Marianne. Thanks for your kind introduction. First of all, I would like to take this opportunity to thank IHF to make this possible. And it is great to present our project here and share with you. This is an improvement drive of the resuscitation service in our hospital. This project would not be successful without our team members, including Ms. Yang Sim-Hung, our General Manager of Nursing, Dr. Leung Kai-ji, the consultant from the Department of Medicine and Rehabilitation, Mr. Lou Kit-wing, the pharmacist in charge, Ms. Phoebe Goh and Ms. Janet Lau, the nurses from the Nursing Services Division and the Department of Ophthalmology, and also the support of all our resuscitation subcommittee members. And of course, the support from our ex-hospital chief executive, Dr. David Lam, and our cluster chief executive, Dr. Lau Cho-chiu. So this is Tung Eastern Hospital. Our hospital was opened in 1929. It is a regional rehabilitation hospital and serves mainly for the population on the eastern part of the Hong Kong island. These catchment areas covered an estimated population of 0.8 million, which accounts for around 11% of the Hong Kong population. Our clinical specialty includes the ophthalmology and the medical rehabilitation. For the medical rehabilitation, we have the subspecialty like the pulmonary, cardiac, stroke, neurology, neurosurgical, orthopedics and traumatology, and musculoskeletal rehabilitation. Our hospital provides 24 hours inpatient service with 256 beds. We also have 4 ambulatory centers with multidisciplinary support. The building of our hospital is a Grade II historic building, classified by the Hong Kong Antiquities and Monument Office. The building design allows limited accessibility of the resuscitation equipment at the same floor. Of course, we can renovate to make this possible, but you can imagine that all the renovation work should be approved by the Antiquities and Monument Office. On the other hand, there were bulky emergency trolleys, with various resuscitation instrument layouts. We have altogether 7 different resuscitation trolleys in the clinical settings. The non-standardized instrument layout in trolleys also caused difficulty in assessing the appropriate emergency equipment efficiently, especially for the staff deployed to the clinical areas. And the hospital resuscitation team is made up of on-call junior doctors and nurses. They have less experience in dealing with this most acute medical emergency as compared with those staff working in acute hospital. Therefore, the objective of this project is to ensure adequate, appropriate, and standardized resuscitation equipment available in the hospital premises and to enhance the staff knowledge in performing the resuscitation and the use of equipment. The improvement was initiated through the Hospital Resuscitation Committee. This subcommittee is under the umbrella of the Hospital Quality and Safety Committee and the Hong Kong East Cluster Resuscitation Committee. Our committee is responsible to review the guidelines, the training, equipment, the cardiopulmonary resuscitation outcome, the audits, and the drills regularly. The direction is in line with the Cluster Resuscitation Committee and the contemporary international resuscitation practice framework. Our members come from different disciplines, including the doctors, nurses, and pharmacists. And the doctors are from the Department of Medicine and Rehabilitation, Ophthalmology, and Anesthesiology. So back to this new initiative, we seek the members' opinion on the proposal of purchasing the new equipment for the standardization, the training mannequin, revising guidelines, and developing new designated response team guidelines and also the audit. After the first discussion among the members, it was submitted to the Hospital Management Committee and approved by the Hospital Chief Executive, the heads of clinical and administrative department. In the following, let me introduce the details of the project. First is the standardization of the equipment. The same model of resuscitation trolleys were purchased to replace the existing different types of trolleys and cover all the clinical areas of need. The new trolleys were relocated to ensure the standardized resuscitation equipment were available throughout the hospital for clinical use and training. We totally purchased 24 resuscitation trolleys. The instrument layout was standardized with the photo label posted. The resuscitation trolleys include the defibrillator, the ambulance bed, the emergency drug kits, and the intubation equipment, and the suction apparatus, and the cardiac pacing equipment, etc. In the previous picture, you can see that the emergency drug kits were also placed in the resuscitation trolley. They were standardized and unified to a drop and shock-proof cases. It is secured by the tie locks with the knock number and the tee-off function. This emergency drug kit can facilitate the drug searching during the emergency drug recall and ensure the security. So we also installed the automatic emergency defibrillators in our hospitals. According to the hospital authority guidance, on the scale of provision of external defibrillators in hospital, the automatic emergency defibrillator is required to be installed in the clinical non-ward low risk and areas and also the non-clinical non-ward high flow areas to facilitate the resuscitation being efficiently delivered to the victims in the vicinity of the hospital. In our 3 automatic emergency defibrillator are installed at the main gate of the 3 building blocks, including the main blocks, the ambulatory center, and the ophthalmic center. These areas are the non-clinical, non-ward areas, but with high flow of public or staff. The AED can be easily accessed by the public and staff, especially the designated response team, to provide the emergency medical assistance. Besides, we have the emergency kit for the designated response team. The bulky emergency pack was also replaced by a handy backpack. Here are the items inside the DRT emergency kit, including the mobile phone, the ball pen and paper bag, and intubation equipment includes the endotracheal tube, the laryngoscope with different size of the brace, and the ETT guide, the McGill forceps, the torch, the syringe, single side plaster, and the lubricating trolley, all the equipment for the intubation, and also the blood pressure monitor, a small scale one, and the O2 tubing, the nasal cannula and O2 mask, and the portable suction pump bed and the suction catheter, the intravenous access including different sizes of angio catheter, the syringe, alcohol whip, tourniquet, etc. And also the first aid items include the sterile dressing set, aqueous solution, sodium chloride, gauze, scissors, micropore, and also the cover bandage like the triangular bandage and the crepe bandage, and an extra gauze pack. For the policy and guidelines, previously we have the resuscitation manual. We revised it to the control document, the policy for cardiopulmonary resuscitation, which describes the cardiopulmonary resuscitation service in our hospital. The control document mechanism provides a chance to review and update the policy, say in 4 years, or review it as required. This policy was discussed in the Resuscitation Subcommittee and approved by the Hospital Management Committee. We also developed the standard operation procedure in handling the persons in need of emergency medical assistance in the vicinity, which includes the referral staff deployment, the designated areas for resuscitation support during the office and non-office hours. So we have purchased the equipment and updated the guidelines. So we need to provide the staff training to let our staff know the new improvement. So the staff training includes the seminars and the workshop so that our staff knows about the update of the guidelines and the related equipment, including inform them about the update referral and the use of the defibrillators. And we also conduct a workshop for the nurse-initiated defibrillator by using the AED in order to enhance the staff understanding and the competency in performing the cardiopulmonary resuscitation. The training video on the use of the automatic external defibrillator was uploaded to the Resuscitation Subcommittee web for the staff easy access. All the staff were required to go through the training at least once. The new initiative cannot be implemented successfully without the performance evaluation and the feedback. We have 4 types of evaluation: the cardiopulmonary resuscitation CPR drill, the designated response team DRT drill, the resuscitation trolley audit, and also the CPR outcome audit. The CPR cardiopulmonary resuscitation drills were held every month by individual clinical departments at different clinical settings. The department staff were required to attend and participate at least twice a year. It is used to enhance staff awareness and competency of performing CPR in the clinical areas. A scenario of the patient started with the bradycardia, asystole, pulseless VT, that is the ventricular tachycardia, and then silence after the defibrillation was used during the drill. The team performance was also evaluated by using the video recording. Debriefing is conducted immediately after the drill, and the video recording is displayed for the group discussion. The auditors are the consultants and the nurse from the Department of Medicine and Rehabilitation, and also the staff of Nursing Services Division. The time sequence of the event and the performance of the team would be audited, including the initial actions when discovering the patient in the emergency, the appropriateness of wearing the PPE, that is the personal protective equipment, the correct site and technique in performing the external cardiac compression, the appropriateness in providing airway support, the intubation, defibrillation, and intravenous therapy with medication, etc. Of course, the coordination of the CPR by the team leader, the actions after the successful resuscitation, the documentation, and also the notification of patients' relatives or significant others would also be audited. The designated response team drill will be performed twice a year at different sites. The objective of this drill is to prepare staff and ensure readiness of the emergency equipment and the smooth workflow. In order to provide emergency medical assistance to the victims in our hospital outside the clinical areas. The staff from different departments were invited to participate and comment. Since this condition might happen outside the clinical areas, various staff be involved, including the telephone operator, the security staff, and the designated response team, which composed of doctors and nurses. To provide an efficient help to these patients, the communication and cooperation among these staff are crucial on top of the performance of the professional staff from the DRT team. Since we have standardized the resuscitation trolley, an annual audit is also conducted to check the compliance of the staff, keeping every required equipment are in place inside the trolley, so as to facilitate staff easy retrieval during the emergency. And of course, the resuscitation trolley checklist together with its documentation are being audited to ensure its appropriateness and frequency of checking in the compliance. Lastly is the CPR outcome audit, the cardiopulmonary resuscitation outcome audit. It is a retrospective audit to retrieve the selected data in all the CPR records and the patient medical records for analysis. The items include the number of the patient being arrested, the age group, gender, the time and location of the arrest, the initial arrest mode, and the time to inform the doctor and the doctor's time of arrival, the time to commence the resuscitation, intubation, and medication. Also, the resuscitation outcome and aftercare, and number of the survival day, the ultimate outcome of the patient, and the documentation will also be reviewed. Hope that the standard and outcome of the resuscitation was monitored for continuous improvement, and to ensure effective resuscitation service are systematically provided for our patients. So all the audit and the outcome results are discussed in our hospital resuscitation subcommittee and uploaded to web for staff easy access. Our resuscitation subcommittee members will also help to deliver the important message back to their workplace for sharing. In conclusion, the standardization of the emergency trolleys and availability of the emergency equipment could facilitate the smooth delivery of resuscitation service. The drill involved a full-scale simulation provide additional resuscitation training. The post-event debriefing helped to improve the confidence of the resuscitation team, enhance the communication and skills in the cardiopulmonary resuscitation. So this is the end of my presentation, and here are the references. This is my contact.
Thank you, Erica. We will go ahead and take some time for questions.
Okay.
So the first question is, if the cardiopulmonary resuscitation is a standardized procedure, why is a policy still required for the resuscitation service? And what is the content of the policy?
So thank you for your question. Although the cardiopulmonary resuscitation is a standard procedure, and suppose the doctor and nurse should know how to do it, a policy is still required, because during the resuscitation, it is not only involved the technique to perform the resuscitation, and our policy also address the composition of the resuscitation team and the roles and responsibilities of different team members, and also include the required training and qualification, and the communication between the supporting staff and the professional staff, and the resuscitation care. Also, the termination of the resuscitation and the overall principles of the documentation and reporting would be included in the policy.
Thank you for your answer, Erica. Another question we have is there a policy for the designated response team?
Yes, for the designated response team, we have as said before, we have a standard operation procedure for the handling persons in need of emergency medical assistance in the vicinity. In the SOP, the communication among different staff, the composition of the resuscitation team, and the duties of the designated response team on the site and the on-site management will be addressed, and also the documentation and the reporting is included in this SOP.
Okay. The next question is, how will you ensure that the drug kit in the resuscitation trolley is ready for use anytime?
So all the drug kits in the resuscitation trolleys are standardized and are supplied by the pharmacy department. The kit would be sent to a pharmacy for replacement after use, and an expiry date was posted on the kit, and the kit would be sent to a pharmacy for replacement when the day is due.
Okay, we still have time for a few more questions. Please type your questions in the questions box and click send. Another question is, how often will the cardiopulmonary resuscitation drills hold in your hospital? And how was the result?
So the CPR drills are held by individual clinical department monthly, and the DRT drills will be performed twice a year.
So what are the common problems or mistakes that you usually encounter during the drill?
During the CPR drills, we find that some of the staff forget to wear the personal protective equipment to protect herself, and also the compressor uh, uh, do the external cardiac compression do not push hard and fast enough during the external cardiac compression. And for the DLT drills, the communication problem may arise because for the DLT is sometimes if happen outside the clinical areas may involve the staff other than the professional staff. And the communication problem is the operator may text the message instead of direct communication with the overall supervisor to initiate the designated response team. So I think the drills is useful to prepare our staffs.
We have another question. When do DRT activate in your hospital, and is it common?
The DRT is activated when receiving the request for the medical assistant in person from the general public in our hospital compound. As it is not common in our hospital, we perform the drills twice a year and hope this helps our staff to familiarize with these procedures.
Okay, it looks like we've covered all of the questions from our attendees. So is there anything else you wanted to cover before I wrap up?
So maybe I just have a wrap up of our new initiative. This project is about the improvement initiative of resuscitation service in Tung Hospital in Hong Kong, and the limited accessibility of the resuscitation equipment and the non-standardized instrument layout in the trolleys would cause the difficulty for the team members to access appropriate emergency equipment for delivery prompt resuscitation service. Our improvement initiative were implemented since September 2012 after the endorsement from the resuscitation subcom, including the standardization and installation of the resuscitation equipment and the guidelines revision and the staff training. We perform the periodic resuscitation drill and audit to monitor the staff performance and compliance after the training. And the debriefing provides a chance of discussion and feedback from our frontline staff. So thank you everyone. It's a pleasure being with you today.
Thank you, Ms. Erica Ho, for sharing your valuable knowledge. The recording of today's webinar will be available on demand at the IHF website. Attendees will also receive a link to view the recording of this session. Thanks again for joining us today, and we'll see you next time. Thank you, everyone.
You.
Goodbye.
Bye.
Thank you, Ms. Erica.
Thank you.